We have created a medical task force with the United Way, with Acadian Ambulance, with Love Our Community, with the Schumacher Foundation and our nonprofit club to address issues with our COVID crisis and disparities in healthcare crisis.
Coronavirus infection is highly contagious, mostly transmitted by droplet infection. If you experience any flu-like symptoms, including muscle pains, fever, cough, shortness of breath, please stay home, quarantine yourself, and seek medical help.
It is still very important for us to avoid large crowds to decrease the spread of COVID-19. Despite being asymptomatic, if one person's infected, you could bring this home to your friends and family, thus propagating this pandemic in the community.
I would have to say that it's very important during our pandemic to be sure that all of us use our mask when we go outside, and we keep distance of about 6 feet or 2 arms together from each other.
There are several locations in the community that's providing free COVID testings. You only have to provide an ID, insurance, and even if you don't have insurance available, they still will do the testing for you at no cost.
Communities of color have been hit the hardest by the COVID-19 pandemic. Well, I've got some news for you. We can take care of you regardless of your ability to pay. We have first-class care that we can take care of you.
COVID-19 is not a hoax. We can stop it in its tracks. You must never go about your daily activities without wearing a mask. The mask, it will prevent the transmission and spread of this deadly virus.
I'm here to talk to you about protecting vulnerable members of the population. Think about helping them attend a faith-based service online. Other things that you can do are running errands for them, like grocery shopping or medicine pickup.
Scrubbing your hands, washing your hands needs to be done a minimum of 10, preferably 20 seconds. You can use soap, water, or hand sanitizers. Minimal 10, but preferably 20 seconds.
Now is not the time to put it in fate's hands. Be proactive. Let's everyone get tested.
Welcome, Acadiana. I'm Dr. David Ollie, and I'd like to welcome you to Dr. Pat Lola and Dr. Ollie's monthly live community medical call-in show. We've got an exciting show tonight. We've got a new procedure that we're going to go over, but I want to call attention to the public service announcement that you just saw. We are still in a COVID crisis. Please wear your masks. Note the masks that we have on tonight, and these are sponsored by our nonprofit club. As a surgeon, I wore masks for 30 years, 6 days a week, 12 hours a day, and those masks were worn at that time to prevent infection and save lives, and that was the life of the patient. We wear them today for the same reason. Again, to prevent infection. Whose infection? Yourself, your friends, your family. Wear your mask. Preventing death also. Your own, your family. The mask is very important. So please, audience, note the public service announcement. We still are in a COVID crisis. Wear your masks. Now, with that said, you can see the four of us here, and I'd like to introduce in a minute Dr. Pat Lola, Dr. Keller, and Dr. Rochon. But at this time, we're going to go ahead for ourselves, take off our masks. We're socially distanced enough, and we've all been recently COVID tested negative as healthcare providers. So we're going to go ahead and take off our masks now, and we're going to begin our program. You can see by the announcement that we're going to be talking tonight about disparities of the aortic valve and the aorta itself. We have had some discussions in another program on disparities in peripheral vascular disease and heart disease, but now we're going to center on aortic valve and the aorta, and I plan to learn a lot tonight myself. We have one of the world's experts with us, and that's Dr. Antoine Keller. We will get to that in a minute. So what I want to do now is a quick introduction to our guests. On my right is my host today, Dr. Pat Lola. Dr. Pat Lola, please welcome yourself and maybe a minute or so real quickly on what this topic means to our community.
Thank you, Katie. So this means a lot to us. So in the next 1 hour, you're going to hear and learn more about this new procedure of aortic valve replacement in a simple fashion from the groin, which has significant improvement in the morbidity and mortality, meaning death rates, and also quicker recuperation time. So we have as Dr. Ali mentioned, we have the best expert next to me sitting. He's going to talk about that. And please go ahead.
We'll go from there. And again, this is a live call-in show. Now, real quickly, Dr. Keller, I want to introduce real quickly. Welcome back home, Dr. Keller.
Thank you, Dr. Ali.
Guys, now Dr. Keller
Good
has
to be
been a
home.
part of this for many years. As a matter of fact, was a member of the group with Dr. Pat Lowell and myself. Goes back 15 years. We were partners at that time. And then, as a matter of fact, this live call-in show, Dr. Keller was my original host. As a matter of fact, I looked back. We have logged over 1,000 hours in live call-in shows with Dr. Keller back in the early 2000s. He now comes back to us. He's in Baton Rouge. I want you to say hello to your audience, Dr. Keller, and then we're going to turn it over to you in a minute to tell us about this new procedure. Dr. Antoine Keller.
Thank you very much, David. It means a lot to me to be back home in Acadiana. Lafayette is very close to my heart, and I really appreciate the invitation.
Well, we're going to hand it over to you in a minute, and we're going to talk about the diseases of the aortic valve and the aorta. I'd like to introduce now, on his right, Dr. Brent Rochon. Dr. Rochon is our partner, interventional cardiologist. Please say hello to the community, and I want the community to know that about a half an hour ago, now make it an hour ago, I got a call from Dr. Rochon. He was on the way to do an emergency heart attack stent case. He didn't think he was going to come. He got here just now. I'd like for him to say hello to the community. Maybe give us a quick rundown on that patient in our community. He just worked on somebody in our community. Dr. Brent Rochon.
Thank you, Dr. Ali. Good evening, Acadiana. I'm Brent Rochon, an interventional cardiologist at the Louisiana Cardiovascular Center and Limb Salvage Center. Actually, I got a call from a referring colleague today about a young patient, very young, less than 50 years old, with chest pain he'd been having intermittently for a month and a half. Upon presentation, the primary care doctor astutely noticed that this patient was unstable and sent him quickly to the hospital. His initial cardiac enzymes were elevated, and as we were always trained to be available. Although we did have a community service project, the patients come first. I rushed over to the hospital, was able to find an occluded artery, specifically the left anterior descending, where we promptly ballooned it and stented it, and the patient is doing fine. If he wasn't doing fine, I wouldn't have been able to make it, Doc. But with the patient stable, I'm here to join back my friend who actually performed heart surgery on my father, who's still doing well. And I'm glad to be here to talk about this interesting topic of aortic valve disease, and which can largely go asymptomatic, and we need to do a better job in checking it and finding it. Then we can fix it.
Dr. Rochon, I'm glad you got a smile on your face. I know that somebody else in our community does. So does the family of that patient that you've just helped. That's real life. Real life. Also, guys, what we're going to do now, also real life, I want the cameraman to come in real quickly. I've introduced this book the last two programs. This is a book written by Dr. Pat Lowell. I'm going to hand it over to him in a second. This is for the community. This is a complimentary book that he has spent 10 years, to be honest with you, writing. I told him I couldn't help him with it. I can't spell or write. He did all this work. Now I show this to you. Dr. Pat Lowell is going to talk about it because, community, we just ordered our first 1,000 books. This is going to be complimentary to our patients, to our club members. Please look in a minute. You will see our club website, our community, as a matter of fact, everybody in the audience. So Dr. Pat Lowell, quickly about this book and the importance, if you would. Community, pay attention. This will be partly something that you will be able to participate in.
Oh, perfect. Thank you, partner, and Dr. Ali. So this book, as Dr. Ali mentioned, this is a work of labor for the last many years. So this book is called as the cardiovascular system. So basically, the entire book is about 200 pages, simply written in a simple language so anybody could understand. The entire purpose of this book is to get you educated in the field of cardiovascular disease so you get actively involved in the care of your patient, of your disease process. So when you read this book, you are fully armed. When you go to see a physician, you can ask all the reasonable questions, and all your questions will be answered in a reasonable way. The entire purpose is to get you involved in the care of yourself and take ownership of your disease process and your body. And thank you, Dr. Ali, for the opportunity.
Thank you, Dr. Pat Lowell. Thank you for all of your work. Everybody look, here you can see, look at the website. please go ahead and get on the website and you'll be able to have instructions on how you can obtain this complimentary book, again, for the community. Now, with that said, I'm going to give a quick introduction on our disease process quickly, and then we're going to hand this over to Dr. Keller, and he's going to explain to you some of the new treatments. So if I can have the first slide, please. What we're going to be talking tonight about real quickly is called aortic stenosis. Now, not getting fancy and real quickly putting this in the hands of Dr. Keller, what this means is the aortic valve, or the last valve in the heart, becomes rigid and causes problems over time. He's going to describe a little bit about it and what we do to treat it today. Now, what do these patients have? They could have chest pain, shortness of breath, congestive heart failure, which we will talk about. They can pass out. This is called syncope. These are the most common symptoms that this condition will have. Now, a lot of that can be mixed up with other things too, so we're going to get into how you sort that out. And you can see also there's a significant amount of these patients who have no symptoms. Dr. Rochon had just mentioned that. In our other programs, when we talked about renal arteries, we talked about carotid arteries, we talked about a lot of asymptomatic disease. It also occurs here in the heart too, and we have ways of figuring that out. So now how do we diagnose it? Well, first of all, a quick good in history and examination, and I'm going to even ask Dr. Keller to mention a little bit about a new Doppler kind of thing that's on a stethoscope that can help. There is EKG, which is a routine thing, and then there's the ultrasound or the echo, which is called a TEE. Not getting fancy, but that is an ultrasound that can look in and can tell us about that heart valve, can tell us about the heart itself. The whole point of this is this disease process is very easily and quickly diagnosed. We're adding the angiogram of the heart because that's something that we will talk about today too, because in the older patients they may have blockages and things like that that go along with it. And so over the years, this condition has been something that we have treated with open heart surgery to replace the heart valve. Now we're going to be talking about a different treatment in which we're actually placing a valve without open heart, and Dr. Keller is going to mention that. Next slide, please. Real quickly, and we're going to move on, there's 4 valves in the heart, and this is the central valve or the aortic valve. That is the one that we're going to talk about and being replaced. The way that I describe this to patients, it's like a door. When the door opens and closes very easily and the hinges are good and greasy and they work well, the door swings open and closed without problems. When the hinges become rusty, they don't work right, the door doesn't open and close. The aortic valve has actually 3 leaves that open and close easily. When they become rigid over time, and this is what occurs, they don't open properly, and that causes strain on the heart. You can see in the red circle the aortic valve. Next slide, please. This is what we're going to do, and Dr. Keller is going to describe this. We actually place a valve into the heart without opening it up. Next slide, please. That is the TAVR. This is the TAVR procedure. I mentioned this real quickly because this is relatively new. He is going to describe what this procedure is. Next slide, please. And in essence, this is the ability to put a heart valve into the position without open heart surgery. As a cardiac surgeon for 25 years, we would open these patients. Dr. Keller himself trained like me. We did many heart surgeries. This was on pump, long cases, hard bypasses, difficult to recover from. One of the biggest things that has changed is these can now be done without even an incision. And that is the TAVR procedure that we're going to talk about. So with that said, I'd like to have the next slide, please. And what we're going to go ahead and do is I'm going to introduce Dr. Keller. Dr. Keller went from Lafayette to Florida to Mississippi. Now he's in Baton Rouge. And during that time, he has been on the forefront of this procedure. Matter of fact, the first of these procedures in this state were actually performed by gentlemen at this table, including Dr. Patlola, including Dr. Keller and myself, back approximately 15 years ago. It has progressed now. Dr. Keller has, in his journeys, has become a specialist in it. He's now in Baton Rouge. He has taken leadership nationally in identifying this problem, especially the disparities portion of it. He's back home where we know where disparities is. He's created a nonprofit himself. Dr. Keller, welcome home. I'm going to turn this over to you. These are your patients. This is your community, and we need to do a better job diagnosing this and treating it without an incision. Dr. Keller.
Thank you very much, Dr. Ali. It is a pleasure to be back here in Lafayette, and I really appreciate all those years of tutelage that you gave me when I was a young surgeon, giving me my first job out of training. So I appreciate the opportunity to be able to learn from you as well.
It was an honor, my friend.
Thank you, sir. So when we talk about healthcare disparities, a lot of people originally jump to the conclusion that we want to talk about outcomes. And outcomes are very important, but specifically as it relates to structural heart disease, the preceding time period before the patient is diagnosed and has their procedure is eminently important in whether they actually have a procedure that is using advanced technology or not. And the disparities related to structural heart diseases when patients have problems with their heart valves are really related to having access to the technology, not necessarily related to the actual performance of the procedure. For instance, patients who have transcatheter aortic valve replacement, if they're minorities or African Americans, or they come from low socioeconomic class where they don't have a lot of money or insurance, when these patients have transcatheter aortic valve replacement, they have the same expectation as a favorable outcome as someone who has really good insurance. It's when they have surgical therapy that they don't have as good an outcome. And unfortunately, patients who are minorities or who live in communities in which there is not a lot of technology, they end up having surgical aortic valve replacement, which is open heart surgery. And the mortality for this procedure is actually 2 or 3 times as much as it is for transcatheter therapy. We're going to go through all of these terms in a little while, but just to set the stage, when we talk about disparities in structural heart disease or valve replacement surgery, we talk about it in a sense that we want to take care of the patient so that they have access to the technology, so that they can have a procedure that can take 1 hour and they can go home the very next day, as opposed to a procedure that takes 4 or 5 hours and they spend a week in the hospital and 6 weeks recovering. So that is the place where we are for our discussion on disparities. You can start my slides, please. We have an organization called HeartSense, which is an organization designed to try to overcome some of these barriers in structural heart disease treatment. A lot of times when patients can't get access to the technology, it's because they live too far away from a center that does the technology, does the procedure, or they might be scared to go to the hospital without their family members because they can't afford to have their family members come to the hospital, or they don't know that they have this problem that they need to have treatment for in the first place. So all of these things are things that can be overcome if we pay some attention to the antecedent problems that are accompany this disease process. So HeartSense is a nonprofit organization that provides financial support and transportation support, and really tries to understand the prevalence of this problem in our community, especially amongst people who don't necessarily have access to physicians and to medical care. It's a really important organization. I've really been proud to be affiliated with it, and I encourage you to support this endeavor. Next slide. So one of the things that Dr. Patlola and Dr. Ali and Dr. Roshan have done over the years is they do a really good job taking care of patients with cardiovascular disease. This graph depicts the reduction in mortality from cardiovascular disease over the last 50 years. And as you can see, the mortality is at a very, very low level now compared to what it was about 50 years ago. And a lot of that is a testament to the hard work and dedication that these physicians have put into trying to discover ways to be able to take care of people less invasively, so that they can go home in a shorter amount of time and spend more time with their families and live long, happy lives. We've done a remarkable job over the last 50 years with innumerable advancements that have helped us take care of patients with cardiovascular disease. Next slide. Unfortunately, in Louisiana, we have not been doing so well because the incidence of death from cardiovascular disease seems to be on the rise, especially over the last 10 years. A lot of people feel that the reason why the cardiovascular disease deaths are going up is because more and more people are developing structural heart disease or problems with their heart valves. Aortic stenosis or blockage of the aortic valve is a disease of aging. So as people get older, everyone will develop some degree of aortic stenosis. Most of the time, it is benign and they never have problems. They don't experience shortness of breath or chest pain or blackout spells, as Dr. Ali was alluding to earlier. They just percolate along and then die of something else. But now that we have baby boomers, which were born just after the Second World War, they're getting older and they're getting into their 60s and 70s, and more of them are developing aortic stenosis. Now that we have a form of therapy that can treat aortic stenosis that does not require open heart surgery, it is something that we're looking out for more and more. And as the population gets older, more and more people are going to have this problem. So it's very fortuitous that we actually have technology that can help them. Next slide. So unfortunately in Louisiana, you can see this graph depicts the CDC death rate from heart valve disease trend in patients over the age of 55. And you can see for Black patients as well as white patients, the deaths from cardiovascular disease related to heart valves is going up as the years go by. Starting to plateau a little bit, and I think that's partly because of the fact that we've become more astute at diagnosing these problems earlier. You know, one of the things that people don't really realize is that it may not be chest pain or blackout spells or shortness of breath that bring you to the hospital, but people will modify their lifestyle to accommodate their symptoms. I had a patient one time who came to my office, and I asked her if she was having any shortness of breath or chest pain, and she said, no, I don't have any of that. So I asked her if she mowed her yard every Sunday, and she said, oh yeah, I mow my yard every Sunday. I'm like, well, do you have shortness of breath or chest pain when you mow your lawn? She said, oh no, ever since I bought that riding mower, I don't have chest pain anymore. So people will change their lifestyles to accommodate their symptoms, and you just have to know how to ask the right questions. And the only way we can get there is by educating people like you and taking the time to watch programs like this. So we appreciate the opportunity to address this problem. Next slide. These pictures depict a normal valve on the left and a valve with aortic stenosis on the right. The valve doesn't actually become blocked where the leaflets don't open fully unless there is some blockage behind the valve. And the blockage behind the valve is caused by cholesterol plaques and calcification and things that happen similar to hardening of the arteries in the coronary arteries that cause heart attacks. It keeps these valves from opening, and you can imagine if the heart is used to pumping all the blood that it pumps to the body through a hole that's about the size of a quarter, and now that hole can only open about the size of a dime, you can imagine how much harder the heart has to work to get the same amount of blood through that little dime-sized hole as it used to get through that larger hole. And over time, people will experience heart failure, which are those symptoms that we talk about. It doesn't necessarily mean your heart stops, but you start to have shortness of breath and decreased exercise tolerance. Next slide. So this graph depicts the aging population, and we have a tidal wave of patients who are going to be in their 60s and 70s coming as the years go by. So this is going to become more and more of a problem in the coming decades. Next slide. One of the problems that I alluded to earlier, specifically with regard to disparities, is that African American patients or minority patients or patients of low socioeconomic standing who don't make a lot of money have a higher risk of death with aortic valve replacement if it's done with open heart surgery, sometimes 2 or 3 times as high as the general population. Next slide. One of the problems that we have in Louisiana specifically is we know that patients who live in certain areas where there is a higher chance of having poverty in the area or in the parish, these patients are more apt to receive surgical therapy or open heart surgery for their valve replacement. Patients who live in metropolitan areas where they are affluent communities have a greater likelihood of receiving transcatheter therapy where they can go home the next day. It's not because we are preferentially treating people with good insurance with transcatheter technology, but it's that these patients in the parishes that don't have a lot of wealth tend to be farther away from places that have access to the technology. We're working on this by trying to provide transportation for these patients who don't necessarily have access to this technology. And as I said earlier, these patients have the same expectation of a favorable outcome once they get to treatment. So it's really important to focus on those times before the patients have to have their therapy so that they can get into a scheme where they can be introduced to a heart team like these gentlemen to be able to direct them into a place where they can have this advanced technology. Next slide. This graph depicts the degree of African American patients. The darker blue indicates the areas in which there are more African American patients per capita. The green dots indicate places where the patients can have surgical aortic valve replacement, and the yellow dots indicate places where you have transcatheter aortic valve replacement. You can see that there are fewer transcatheter aortic valve replacement hospitals, but yet and still the places that have the darkest blue, which is the highest percentage of African American patients, are usually farther away from these places with transcatheter therapy. So we have access issues related to location. We call these TAVR deserts, or places at which you can't have access to the technology, so therefore you have surgical aortic valve replacement. Next slide. And this slide depicts the percentage of patients with aortic stenosis who actually receive transcatheter therapy. Majority patients are on the top line, which obviously they are more apt to receive transcatheter therapy, and the African American or minority patients are on the bottom line. The one problem I have with this particular slide is that these lines are not parallel. The gap is widening. More patients from majority groups are receiving transcatheter therapy, and fewer patients from minority groups are receiving transcatheter therapy because of the reasons that I alluded to earlier. Next slide. So African American or minority patients and patients who have low socioeconomic class have less of a chance of receiving transcatheter therapy, and when they receive surgical therapy, their risk of death is a lot higher. This is a problem, and it's not just related to being in a minority group, but for every $10,000 increase in the household income of a patient, they have a 10% greater chance of having a transcatheter operation. So something that we really need to shine a light on so that we can all do our part to try to alleviate this disparity. Next slide. There are a number of reasons why, a lot of which we have already discussed related to transportation and access, and ways in which we can help reduce the amount of disparities that we have in our communities. Next slide. And next slide. And a very good friend of mine, Dr. Wayne Batchelor, has written a paper that outlines the steps that we need to take at every step along the way to try to see if we can reduce these disparities. Next slide. The most important thing is to have an action plan and have a coalition of people that are willing to attack this problem and keep it on everyone's minds, educate the community, educate primary care doctors, educate family members of our patients so that we can try to reduce the amount of death from cardiovascular disease related to valvular heart disease. This is one of our projects with HeartSense, where we are focused on trying to understand what the prevalence of heart murmurs are in the community so that we can understand how well we're doing at getting people who have these heart murmurs to places where they can have the right kind of therapy. This is the only way that we're going to be able to incentivize our elected officials to reimburse these kinds of procedures better in disadvantaged communities. Next slide. So we invite you to join our Cardiac Disparities Coalition. You can find a link to it on the HeartSense website. We would all be interested in understanding your perspectives with regard to how to overcome these barriers for treatment for cardiovascular disease in general and for valvular heart disease specifically. Next slide. And we want you to help us, because the only way that we can understand what you need in the community is for you to communicate that to us. So we really appreciate the opportunity to be able to describe what the problem is to you, and we want you to try to help us find solutions. Next slide. So a little bit more about the transcatheter aortic valve technique. We go in through the groin through a little needle stick. We deliver a catheter up the big blood vessel that provides blood to your body called the aorta. We park that artificial valve inside the old valve, and we push all that calcium to the side, open up the new valve, and it allows you a super highway for the blood to flow through as opposed to a little dime-sized hole like we talked about earlier. The whole procedure takes about 30 minutes to 45 minutes, and it has changed the paradigm for taking care of patients with aortic stenosis. This is an X-ray picture of what it looks like while we're blowing the valve up inside the old valve in the patient's heart. You will see the stent valve there on the wire, and the balloon goes up and it expands the valve and pushes all that calcium to the side and allows you to have free flow of blood from the heart to the rest of the body. It is really miraculous, and even though we do it every day, I marvel at it every day. Next slide. Again, please support our HeartSense organization as well as the CLI and Limb Salvage Club of Dr. Ali, Dr. Patlola, and Dr. Roshan. These organizations are really interested in helping people, and we really want to make sure that people in our community can be healthier and happier, because we feel that rising tide lifts all boats. Thank you very much.
Dr. Keller, I'm honored. I knew that I was going to learn something, and I know that Acadiana and our audience has too. To our audience, I am a cardiac surgeon who has actually about 40 years of experience. Dr. Keller himself, a cardiac surgeon with 25 years experience. He's describing to you as a heart surgeon, a procedure in which he used to do open heart surgery. Now he doesn't have to do that for his patient. He can actually do a non-surgical procedure and send the patient home the next day. So in the world of medicine, we've seen many, many great things happen. And to be honest with you, this is one of the major shifts that I have seen myself over these years. And Dr. Keller, I understand why you're marveled every time you do this. Because in our training, we used to spend 4 to 6 hours. We used to have these patients not go home. We used to have them recover slowly. It was a very difficult procedure for them. Today, non-surgical, we need to look for it more. We are treating less of a minority. We need to be getting this in the hands of many more patients. Dr. Keller, thank you for educating our audience on this. And I'm proud of you, and I'm proud to have been, watch what you have done over these last 2 or 3 decades yourself. Thank you
very much.
Okay. So guys, what we're going to do now is we're going to bring on our live call-in. We're going to get into some of this. We hopefully will have some questions that will get us in a little bit deeper. So with that said, can I please have our first call-in, please, and we'll take it from there. You see our live call-in number. Thank you. Thank you, Dr. Keller.
Good evening to all of the doctors. First and foremost, thank you for these awesome educational programs. They have been a blessing to me and some of my family members. My father had an aortic valve replaced and 4 bypasses at the same time by you, Dr. Ali, about 20 years ago. Today, how are blockages in the coronary arteries handled without open surgery on patients when they need a T-bar?
What a question. I must have done that when I was in high school, if it's been that long ago. In all seriousness, this is a pertinent question because in those days we had coronary artery blockages and valve problems too. We didn't have all of the things we had today, so we actually had to replace the valve and do bypasses at the same time. So I'm going to ask Dr. Roshan to field this question as a cardiologist, because now we've got the ability to do this transcatheter, but we still have the arteries of the heart. How do you guys as a cardiologist deal with heart blockages in the face of this valve? Because I think you can fix them all now without surgery. Dr. Roshan.
Question. Thank you. Actually, I did similar procedure earlier today. What we would do is perform a coronary angiogram, much like the video you saw Dr. Keller show, where we would pass catheters up into the arteries of the heart or the bypasses in your father's case, and inject dye and take live x-ray pictures to check for blockage. If that blockage is found, including in the pre-operative workup for a trans-aortic valve replacement, we can open this with a balloon and then a stent, which is like a metal scaffolding or a spring that we leave in there for that artery that we opened, which is an elastic structure that may also be calcified, to stay open. The stent acts like a metal scaffolding that we leave in there so we can prevent from this blockage from returning. This is very important also for us to do whenever we are working the patient up, that, hey, we realize this patient has aortic stenosis that has developed, and we do this preoperatively to see if patient does have blockage. And if it is amendable to angioplasty or stents, we fix these prior before we send them to our specialists who would do the transaortic valve replacement. Thank you.
So in that way, you see they're treating both of these without any incision whatsoever. Marked change. Can I have another call, please?
Good evening, doctors. Thank you for taking my call. I have a question for the cardiologist on the panel. How do you, as a cardiologist, evaluate your patients who need an aortic valve replacement? And how is it determined whether they need an open versus femoral approach or TEVAR?
Again, another perfect question. Dr. Palola, this is something that you do on a regular basis, and give us the information that she's asking. How do we really make that decision as a cardiologist getting involved?
Very good question. So, believe it or not, it always starts with pigs in this profession. Medicine and surgery. We always experiment these new things on pigs. So, in early 1980s, a Danish physician got this concept of using this simple, minimally invasive valve to be implanted from the groin. And it was a joke. Everybody laughed at him, but he still tried to implant them in the pigs, and the pigs did well. So in 2012, my senior partner, Dr. Ali's friend in France, his name is Alain Cribet. So he did the first procedure on his own father-in-law. So it was kind of tricky, but he did it. The man was very sick, could not be touched by any surgeon. So he said, I'll do it on my father-in-law. And he did it from the groin, minimally invasive. Took about 2 hours those days because it was still very preliminary. And the man moved on to live for the next 15 years and is still alive, I guess. So that was history. So in this country, the first valve was approved by FDA in 2011. So that approval was very simple. It has to be only in prohibitive risk patients, meaning if this patient goes for open heart surgery, the risk of him dying during or immediately after the surgery is more than 20%, which is an extremely high risk in our profession. In our profession, we always look at single digit. We want the mortality, meaning the death rate with any surgery or any procedure should be less than 3%. Okay, so this is more than 20% risk. So they said, well, we're going to approve this. This was 2011. In 2012, 1 year later, FDA approved this procedure for high-risk patients, meaning in people who have a risk of dying from this procedure immediately or during the procedure of more than 13%. And these patients did fine, extremely well, with almost less than 3-4% mortality, a death rate. So then subsequently many things came up, meaning they started doing valve and valve, meaning people who have previous pig valves or cow valves implanted in them, those valves get clogged up in 10-15 years, sometimes in 20 years. So when those valves clog up, in the past we have no other option but to do another repeat surgery. But the FDA approved this procedure that this could be done in people who have this pre-existing pig valves or cow valves now clogged up. We can use these valves. These patients did well too. So in 2017, they extended this to people with intermediate risk patients. And most recently, 2019, this procedure is also approved in patients who are low risk as well. But there are certain criteria, meaning there has to be some kind of a calcium deposition around the valve, and it should not be a leaky heart valve, most important thing. And then it has to be a structurally normal valve. As Dr. Ali mentioned, the aortic valve has 3 leaflets, and let me show you 3 leaflets. And if one is missing, we call it as bicuspid valve. If two are missing. We call it as a unicuspid aortic valve. So these are abnormal valves, born with abnormal valves. So we prefer not to use these valves on them because we don't know exactly the long-term outcomes in this patient. So as of now, any patient, intermediate, low or high-risk patients could be entitled to this procedure in a safe fashion with excellent outcomes. And we had the proud privilege of doing this procedure myself under the leadership of my partner, Dr. Ali. In 2012, we were the first in town to do it. And since then, we have done several procedures. And right now, we are very young, very able cardiovascular physicians and surgeons in this town at all 3 hospitals who are doing a phenomenal job with this procedure.
Well, you can see to the caller, there's a reason and there's specifics that we follow to do this. As Dr. Patlola mentions that, I just happened to reminisce back myself. Dr. Alan Cribier I had met, I knew. As a matter of fact, the first transcatheter meeting ever happened in 2004. This was actually 6 or 7 years before this occurred. I happened to be one of the guys invited to that. This occurred in London, as a matter of fact. So there was a 6-year period of time where he had worked on this until it came up in which he used it in his family member. So there's a lot of history, and I'm smiling to remember those days. So with that said, can I have another call, please, and we'll take it from there.
How long do these heart valves last? Because I understand the old heart valves only lasted 10 years.
Okay, Dr. Keller, that's up your alley. But as a heart surgeon, knowing how long these last, you can even get into some history, and and we're going to let you address that and for our audience, and then I'm going to tell a little story too.
Okay, yeah. It's a very good question, and one that we have to consider a lot now that we have such great technology that can allow patients to go home the very next day. One of the concepts that we consider when we talk about aortic valve disease is the lifetime management of these patients. So we understand that these tissue valves have a limited life expectancy. About 80% of them will last 15 years or so now with the new preservation techniques. But that means if it's a younger patient that they could risk having to have another operation at some point in time in their life. And if we're using transcatheter techniques where we put the valve inside the calcified aortic valve and expand it, and then we have to put another one inside that one and another one inside that one, the hole gets smaller and smaller and smaller every time you try to put more metal inside. So we have to consider in younger patients what the appropriate cadence would be, whether you should have the transcatheter valve first, and then if that valve wears out over 15 years, then you have surgery to put a surgical valve in, and then if that one wears out, then you can put another transcatheter valve in. If you put more transcatheter valves in the same hole, then you risk being able to obstruct the coronary arteries or not be able to provide the stents that Dr. Roshan was talking about at a later date. So there are a lot of pros and cons, and the most important thing that you should know when you're considering having a valve replacement therapy is to go to someone that can outline all of the risks and benefits and alternatives for you, because each patient is an individual. We don't have a cookie cutter that says this is good for every single patient. So it's really important to find smart doctors who understand the breadth of the technology and also understand the limitations of your particular situation. But it's a great question. There are other types of heart valves. We have mechanical heart valves that will theoretically last forever, but they commit you to taking blood thinners for the rest of your life, and a lot of people don't really take too kindly to the blood thinners for a number of reasons. But there are a lot of options, and the most important thing to take home from my answer to that question is to go to someone who has access to all of those options and can give you an educated opinion about what would be best for you, and to make a shared decision about what would be best for you.
As suspected, I learned again, and then the answer here is obviously there is no single answer to this, and everybody's a little bit of an individual. And I'm going to opt on my story until the next show, just in respect for time. So can we go ahead and have another call, please?
Yes, how common are abdominal aneurysms, and how can they be fixed without an incision?
Well, I'm going to take that one myself, guys. So I am going to go ahead and tell a story, but it's going to be about abdominal aneurysms. Can I have a slide, please? Because that is one of the diseases of the aorta. Can I have my first slide, please? Because I got a little something I want to present to that. Because just as in the transcatheter aortic valve replacement, we've seen a major change in abdominal aneurysm treatments. Real quickly, what is an aneurysm? Well, it is not the atherosclerosis or the hardening of the arteries. On the contrary, it's the weakening of the arteries, and it occurs in the abdominal aorta. And it's very common. It's thought that between 10% of every male over the age of 70 is going to have some degree of a weakening or aneurysm over time, so it's common. 90% of all aneurysms in the body occur in that spot. Now they can occur in other places, as you can see by the slide, but generally the abdominal aorta where you bend. It's the number 10 cause of death overall and number 7 in males. So it's a common problem, and now we're talking about the aorta, not the aortic valve. There's almost 180,000 deaths per year for abdominal aortic aneurysms, and we know they run in family history. 1 out of every 4 will have a history in the family, as we're learning. Next slide, please. So males do tend to have this more than females, but females are catching up. Why? Because of age, because of smoking, etc. Over time, their aorta is affected also. So the risks here are age, because just like everything else, there appears to be an increase in time or aging. The disease process or the weakening occurs with age. Smoking has a direct effect not only on the artery blockage, but is also weakening, and we know there's a family history. Females, they tend to even rupture more frequently and at smaller sizes. These are just some things about aneurysms, and I'm going to get into it. Let's have a next slide, please. The natural history of this is expansion and rupture. Now that doesn't mean overnight, but we know by natural history that just like, let's say, a girdle, as it gets larger, it gets weaker. So the same thing over time with the aorta. Now, when an aneurysm ruptures, 50% of the people, as a rule of thumb, are going to die immediately. Why? Because it's the largest blood vessel in the body. Quite frankly, 2 or 3 pumps and a person can actually die. So what do? We know that 50% of them, after they rupture, they are alive, but these people are sick. Those people have a ruptured aneurysm, they're in shock, they have to go to the emergency for emergency surgery or some kind of repair, and they are sick patients, and 1/4 of them do not survive the rupture. So in all, 1 out of every 4 aneurysm, if it ruptures, is going to have a bad outcome. What do? We got to identify it, we got to fix it before it ruptures. That's the history of aneurysms. Next slide, please. So these people can have pain and immediate death, shock, abdominal fullness. They can have little blood clots. Now these aren't vein clots, but these are little artery. Pieces of this aneurysm can actually flick off and go into the legs and the feet. This is called blue toe syndrome. Your doctors will know about this. Now, you can also have no symptoms. So right across the board, you can see there is a complete range of everything there. So it takes not only a symptom, but also the diagnosis by considering it can be there without symptoms, just like everything else that we deal with. So how do you diagnose this? We have the history, which we've talked about. We're going to talk about an ultrasound because it is simple, it is easy, it can depict the aneurysm itself. And then we have a special kind of CAT scan that tells us about the aneurysm and then also tells us how we repair. Next slide, please. So we have a CMS approved prevention program in aneurysms called the One-Time Payment Plan. We don't do this enough. This was okayed by CMS in 2014, 2015. That means that every male over the age of 65, anyone with a family history, and if you have a smoking history, you can have a free abdominal aneurysm at your physician's office by going with this plan. We need to do a better job with it. This is why we need to identify these before they rupture. Next slide, please. So here is an abdominal aortic aneurysm. You can see that little horseshoe thing in the middle. That is the aorta. Next slide, please. This is how we fix them today. Now, just like the transcatheter aortic stenosis, we used to replace that aortic valve. Now we replace it with a transcatheter valve In aneurysms, we used to have to cut out that aorta and sew in by hand a new aorta made of Dacron or a prosthetic material. And again, that's a 4 or 5 hour operation, very high morbidity, difficult to recover from. The patients don't do as well, but it saved their life. Now, over the last decade, matter of fact, decade and a half, because I'm going to show you the original one of these that we did in 2002, you're seeing the elements of how we fix these aneurysms through small sticks now without even an incision. Look at that. Those are the components. Next slide, please. Here's how we now replace this by placing this on the inside, excluding the aneurysm. Again, a procedure without incisions. Next slide. This shows an aneurysm. This is exactly what it looks like. You can see that big weak spot. You can just sense that is about to rupture. Next slide, please. This shows us placing the stent graft to exclude this and to fix it. This is a final angiographic result. Next slide, please. Here you can see before and after. This is an abdominal aortic aneurysm. Common, you saw the statistics. Aging population, we need to do a good job and continue to diagnose these because we have a treatment now that is done quickly and the patients go home the next day. Next slide, please. Here you can see actually in circle there is 2002. We actually did the first of these in this particular area. Now that's 18 years ago. Dr. Keller, I think you were kind of coming at that time too. And so we became a training program, and so we have trained quite a few physicians through the years with this procedure. And this is the original one in 2002 as we're getting into history. Next slide, please. Can I have my next slide? So what I'm going to do is I have a video, if you can start the video. This actually shows how we place the catheter, and you can see in the hands that it will start turning, and what this does is we deliver this stent graft on the inside without any incisions, and we unfurl this sheath, and believe it or not, this stent graft, which we had to cut and sew, is deployed right below the renal arteries. This shows how we're doing it by hand. This is a common procedure. As a matter of fact, Dr. Pat Lowell and I will be doing one on Friday on a female. Here you can see we pull this catheter back, it puts it in place, and we are deploying on the inside, fixing it from the inside out through a non-incision through a little hole in the artery, which we'll talk about. Now you can see this device is pulled back, and we have in place the stent graft itself. We then remove this sheath. The sheath is pulled back and it pulls out, and what it'll do is it'll leave the stent graft in place just like you're cutting it and removing it and sewing it in place. This was done by also friends of ours who started this. Dr. Juan Perotti and Dr. Tom Fogarty are the names who did this. They are friends of everybody at this table. They are legends in our field, and as a matter of fact, both of them are still alive today. They created this in our lifetime. This shows how we place this. Now we have excluded the top part in one leg. Now we have to come up with another stent graft, another limb to put on the other side. It's placed in this particular fashion. We blow it up and it will put in place the stent graft itself. This will show how we then go ahead and deploy, and we will have had secluded off both of these. What we'll do is go ahead and now follow, and you will see a balloon that will be inserted, and that balloon will go inside, and it will blow up, and it will deploy, and it will almost seal this in place. So once this goes in, it will go in, and we blow the balloon up. It is like sewing it. This remains in place. The blood will flow through the stent graft, and we have excluded the procedure. We have another video, but I'm going to skip that video because it's really a little bit repetitive. So there is what aneurysms are, very analogous to what Dr. Keller had presented. We correct these from inside out. Let's have another caller, please.
I heard of a new procedure in which the doctors can work from the toes to the groin from below to open up arteries. Can you comment on the new type of procedure from the foot?
Yes, we can. This is more a little bit on the peripheral vascular system. Dr. Pat Lola, you only got about a minute here. If you could really quickly describe this. Quick picture, please.
All right, so it's quite a simple a way to do things. If we cannot cross from above, meaning we cannot unclog the blockage from above, we try to go from below. And we have done thousands of them. And for some reason, it's so much easier to unclog a blockage from below. It takes a little bit of expertise and training, but we have done quite a few of them. It's a very simple thing. We get a small axis, like putting an IV line in your ankle area. Next slide, please. And then a wire is advanced through the blockage. And then after the wire is advanced all the way up to the groin, now the things are reversed. We don't want to do any more procedures from the leg, because these arteries in the leg are quite muscular, and they get into spasms. So we complete the entire procedure from up top. It's quite simple. It has a little learning curve, but it's reasonably doable and with an excellent outcomes.
Dr. Pat Lola, thank you. Could we have the last slide, please? And we're going to close. We would like to, audience, thank you for calling in. We had a lot of information. We've shared it. We will be back with us next month. Last slide, please, showing us our next program. And I want to thank Dr. Pat Lola, Dr. Rochon, also Dr. Keller for an excellent program. We wish we had 2 hours. We hope to see you guys on December 2nd for our next show, live call-in show. Dr. Keller, thank you very much.
Thank you, sir.
Well, I went 30 seconds over.
That's all right.
Thank you.
That's all right.